So Mariana, thank you so much for doing this for us. We really appreciate this.
Thank you. It's my honor and pleasure to do it. And thank you to everyone that's attending today. I hope what I'm going to say is useful for you.
Absolutely. And so we are really honored to have a grand round speaker today, Dr. Mariana Dalaqua. Dr. Dalaqua is a faculty neuroradiologist and a deputy head of neuroradiology at Valais Hospital in Switzerland. Her topic today is head trauma, and she's a renowned neuroradiologist. And we are very lucky and honored to have her present the Health for the World International Grand Rounds today. As always, feel free to introduce yourself in the chat box or at the Q&A box with your country. And I hope everyone is doing well during this time. For those people who celebrated Thanksgiving yesterday, hope everyone had a good Thanksgiving. All right, Mariana, you can start whenever you're ready.
So today, as Dr. Brenner has already introduced me, I'm going to talk about head trauma. So, well, first of all, I have no conflict of interest. This is important to say. So how is it going to be? So the structure of the lecture, I'm going to start with the epidemiology, and then I'm going to talk a little bit about primary versus secondary injuries, and then the usefulness of diagnostic imaging in this context, the advantages and disadvantages of each image modality, the useful tips to analyze CT and MRIs, and a review of the basic types of intracranial findings. And the last part would be a real-life experience case-based review of 12 different cases. So let's start with the epidemiology. So here is a little map that shows the incidence of traumatic brain injury by each World Health Organization region. So the green areas, the most green areas, they are with the more important incidents. So here we see that would be Canada, United States, and afterwards Europe, Asia. And we should say that traumatic brain injury is a silent epidemic. So it contributes to the worldwide death and disability more than any other traumatic insult. This is very important. The global incidence of all cause, all severity TBI is estimated at 939 cases per 100,000 people. That means that there's an estimated 69 million people worldwide that will suffer from TBI each year, and it's a lot. So that's why every radiologist should be familiar with the topic. So here is the map that I've showed you before with some other information. So on your right, you can see these blue bars. They show each region of the World Health Organization. And here, the last two bars, inferior bars, show the West Pacific region and the Southeast area. Okay, so these have in absolute number, the most important cases. And here in the inferior right part, you can see a map that shows the incidence of road traffic collisions. That would be more important in the South American continent and in Asia. So here there is this pitfall that would be registration of the cases that we don't know exactly if they are the same in each area of the world. But anyway, road traffic collisions are a very important cause, as we're going to talk later on. So of all TBI patients, 10% more or less have fatal injuries, and 5 to 10% will have serious and permanent neurologic deficits, and 20 to 40% will have moderate dysfunction. So it has an economic burden that is very important, not only for the patient himself, but also for the family, okay? And as I have already said before, road traffic injuries are the most relevant mechanisms. So we have to remember that most affected patients are young men, but falls are also important, mainly for children that are younger than 4 years old and elderly people that are older than 75 years old. We shouldn't forget about that. So, talking a little bit about the differences between primary and secondary mechanisms of injury. So primary, we would have the scalp and skull injuries. We should not underestimate scalp lesions because they bleed a lot and the patient can exsanguinate from them, mainly if they're babies, okay? So it's something that should not be overlooked. And Talking about primary injuries as well, we have extraaxial bleedings. We're going to explore it further afterwards. We have parenchymal injuries, and we have other types of injuries like perforating wounds, some pitfalls that we're going to talk about, and non-accidental trauma that would be a subject for a separate lecture, but it's a very important topic. And talking about secondary injuries, there are injuries that we're going to try to prevent. Okay, we cannot prevent many times the primary injuries, but we can prevent some of the secondary injuries. So herniation syndromes, cerebral edema, brain ischemia, and secondary vascular lesions. Vascular lesions can be primary as well. So keeping the patient well oxygenated with a low CO2, the right head decubitus, all of that are measures, the right tension, all of that are measures to try to avoid secondary injuries. So we should talk about that. So in the context of head trauma, what is the usefulness of diagnostic imaging? So it's very important, as we all know it. It's important for the identification of treatable injuries. It's important to define the approach. Is it going to be a clinical approach versus a surgical approach? How do we monitor treatment? It would be with imaging as well. Detection, as I said, of secondary injuries and estimation of prognosis, okay? So let's talk about X-rays. What do you think? Do you think X-rays should be used to assess traumatic brain injury? Think about 1 little minute, and then I can have a little bit of water. So some would argue that yes, if you have a fracture, then your patient is definitely under the risk of a more important parenchymal or trauma or extraaxial bleeding. But I would argue that no, because X-rays, they have an 80% rate of false negative results for the detection of intracranial injury. So if you have a negative X-ray, it doesn't mean at all that the patient doesn't have maybe a fatal injury, okay? He can have or she can have a very important injury even with a normal X-ray. So almost a third of deceased patients, they do not have any recognizable fracture. So I would argue against the use of X-rays in the context of acute head trauma. And I would argue that we should go for CT, okay? And I'm going to comment a little bit on MRI afterwards, but as you know, CT has some important advantages in this context. So let's go on. So CT or MRI? CT is more available, CT is cheaper, it's faster, because many times patient has hypoxia. Hypoxia leads to an agitated patient, or sometimes the patient is already intoxicated with alcohol or drugs, and it's always a faster method for children as well. It has a higher sensitivity to fractures and acute bleeding, and it also allows vascular analysis with CTA, okay? Otherwise, MRI provides a better definition of meninges of the encephalic parenchyma. It has absolutely a higher sensitivity in the detection of small and deep and infratentorial lesions and bleeds. We're going to comment about it later on. But there is a disadvantage in the context of trauma, that is the magnetic field and also the availability. We don't know sometimes if the patient has a pacemaker, if the patient has a cochlear implant, or if the patient has a foreign body that is close to an important artery, or so on and so forth. So mostly we're going to do CT before MRI, okay? MRI normally is reserved for a second time. So some useful tips for interpreting an exam of head trauma. So always systematize your analysis. This is very important, because if you don't do things in a systematic fashion, you're going to miss, okay, important findings. So I would suggest that we look from the outside to the inside, because we know as a general rule that in the context of head trauma, the deeper the lesion, the most severe the injury, right? So Subgaleohematomas are friends of the radiologist. Sometimes we rush, we look at the bone, we look at the parenchyma, and we forget to we forget to search for the subgaleohematomas. And in fact, they're very important because if you find a subgaleohematoma, then you're going to look for the bone that's just beside of it, and you're going to search for a fracture. If you have a fracture, you're going to search for an extraaxial hematoma, and then you're going to look 180 degrees on the other side and look for the contracup injuries. So always look for the subgaleohematomas. They are very important. On CT, we should absolutely change the window and level while we are analyzing the examen, because we know that if we look with only one window, we're going to miss subtle findings. So it's very important to search for abnormalities using different windows and levels. And use the tools you have on your PACS. Okay, so if you have maximal intensity projection images, that may help you to find blood. That may help you to find the subtle subarachnoid hemorrhages. So use your tools. The same thing goes for 3D reconstruction. So if you look for the axial images and you try to understand a fracture, sometimes it's difficult if it's misplaced, if it has different conformation than you're used to. And if you have a 3D reconstruction, why not use it? It's much easier to understand what's going on. Even in post-op images, if you have a craniotomy, you want to make sure if it's frontoparietal, if it's temporal, always use a 3D reconstruction. It makes your life much easier, okay? So we're going to talk about some fundamentals of trauma, and then we're going for a case-based review. So let's start with the extraaxial hemorrhages. Here, we should remember that on CT, they are always hyperdense in the acute phase, and afterwards, attenuation decreases 1.5 Hounsfield unit each day. So around the end of the first week or 10 days, the hemorrhage is going to be isodense, okay? And after the 10th day, the hemorrhage is going to be hypodense. So MRI may be useful for anemic patients for smaller and posterior fossa bleedings because MRI is more sensitive than CT in this context, okay? So talking about extradural hematoma, here we see an oblique fracture going from the parieto-temporal junction. It crosses the suture and it has a very characteristic localization. So it's associated to the path of the middle meningeal artery classically and is related to the epidural or extradural hematoma, okay? That is typically biconvex like this. This is the typical aspect of the arterial extradural hematoma. And here is an image from the Osborne's brain book that shows the path, the trajectory here of the middle meningeal artery. So we see its relation with the epidural or extradural hematoma. Here is another case. So we have a patient with a large contusion. We see a large zone of cortico-subcortical edema and some interparenchymal hemorrhage. And here we have another type of hematoma that would be in a semilunar morphology like this. So this would be a subdural hematoma, hyperdense, so acute, okay? Going on for a different patient now, we see on the left that there is something here that occupies space and has the same density of the cortex. And sometimes it can be missed by less experienced radiologists because mostly if it's bilateral, that it can happen bilaterally, less experienced radiologists may find it normal or may misunderstand what's going on. So here we have a isodense subdural hematoma in a subacute phase, okay? So we should not let this pass. We should not forget to search about it. We don't have a cortex that would be thick like this. We should always consider there's something else. So if you look at the same thing in the MRI, we see that subdural hematomas already have methemoglobin. So methemoglobin is hyper has a hypersignal on T1, has a hypersignal on flare, usually after the third day that it appears. And here we see that there is a little deposit of the figured elements of the blood posteriorly. Okay, so here's the aspect on the MRI of a subdural hematoma. So going on, this is another patient that has already been drained before. We see the air. And now he has a hypodense collection along the left cerebral hemisphere, convexity. And here in the posterior part, we see a hyperdense component. So here we have chronic hematoma, okay, a hypodense, and that has had a bleeding in the interval, right? So it has a mixed density, but most of it is chronic. So going on, we have another type of extraaxial bleeding. In this case, it's subtle. We have closed a little bit the window, so we see some hyperdense, just a cortical bleeding in a child, okay, frontal, orbital, opercular, and a little bit here higher. So this is subarachnoid hemorrhage, and it can be overlooked if we don't play a little bit with our gray levels, right? So here's another case, a special one. You see the arrows, they are pointing to the cisterns of the middle cerebral artery. But here we have something different. You see the supratentorial parenchyma is a little bit hypodense. We have a loss of the distinction of the gray matter and the white matter in the supratentorial compartment. And if you look at the cerebellum, it's a little bit white. So this is the sign of the white cerebellum. It's a sign that's classically found when we have cerebral edema, when we have an hypoxic ischemic injury. So this would be the normal vessels, okay? They're not hyperdense, they are normal, but they seem hyperdense because the parenchyma that is adjacent is abnormal. So in fact, this is a case of pseudo subarachnoid hemorrhage that should not be mistaken for a true bleeding, okay? This is a pitfall. So going on, we have another patient here that has bilateral lesions. So on the right, the patient has an extraaxial hemorrhage, an epidural hematoma biconvex. And on the left, we see that there is a large hemorrhagic contusion with this hypodense area that represents vasogenic edema. And here, adjacent to the contusion, we see a subdural hematoma, okay? So we have a combination of a lot of findings that should be properly recognized. Wow, so now we're going to start our case-based review. So after the cases, I'm going to stress some important topics, okay? So case number one is about a 43-year-old man that was riding a bike to work. So what happened? He had a right parietal fracture here, not very much displaced, but we see that this fracture extended inferiorly to the temporal bone, to the mastoid. And on this third image here, we see that it displaces the ossicles of the middle ear on the right, okay? And we don't see a very clear extension to the optic capsule. So what does it mean? It means that this patient probably is going to have some degree of conductive hearing loss, okay? We as neuroradiologists or general radiologists, we should be able to recognize this subluxation here, because even if it's not going to be treated in the acute phase, it can be corrected surgically afterwards, and it can improve this conductive hearing loss. And we should always verify if this patient has a problem with the facial nerve, okay, we should always try to understand if the fracture extends to the facial nerve canal, because this patient may have a facial paralysis, and sometimes he should be decompressed very quickly, not to have an ischemia of this nerve. And we should always actively search for the extension of the fracture to the optic capsule, because in this case, this patient is going to have a sensorial hearing loss, and it's not something that can be corrected surgically, unfortunately. So in this case, we didn't see an extension of the fracture to the facial canal, and we didn't see an extension to the optic capsule. It was only displacing the ossicles, okay, the malleus and the incus. So moving forward, we see the extension of the fracture here, right? And let's go on. These are the soft window images. So we see here on the right an epidural hematoma. On the left, we see a little bit of subarachnoid hemorrhage. And the same thing in the second image. And here in the third image, we see a lot of intraparenchymal hemorrhage. And as this was a very acute phase exam, we don't see a lot of edema. So edema normally tends to increase after the first 24 to 72 hours, okay? So here in this very acute phase, there was not a lot of vasogenic edema yet. So moving forward to the second case, it's about a 46-year-old man that fell from 5 meters while making electrical repairs. So here we see as well a fracture, okay? There's a little bit of diastasis of the occipital temporal suture, and we see an extension here to the right occipital condyle that transpasses the region of the jugular bulb on the right, okay? And there's a very important finding here. There's a little bulb there inside the carotid canal on the right. And if we zoom, we confirm it, okay? So if we see something like this, if we see a skull base fracture and we see air where there shouldn't be, we should absolutely inject the contrast, okay? We should absolutely do a vascular study to understand what's going on with the vessels, right? So in this case, the patient didn't have an arterial lesion, but if you look at the transverse venous sinus on the right, you see that he's detached from the bone, and there's the interposition of an epidural collection with some bubbles of air, okay? And if you go on to the transition of the transverse and the sigmoid sinus, we see there is a traumatic thrombosis, okay? So we found something else that we weren't looking for at the first place. We were looking for an arterial lesion, but in fact, we have found a venous lesion, and it should absolutely not be neglected in our reports, okay? So another case, the third case, about a 52-year-old man that had a motorbike crash against a power pole. So here we see some 3D reconstructions. The patient had bilateral oblique fractures. So on the right, we see the extension, the parieto-temporal extension, a zygomatic fracture, and on the left, even more displaced, also an oblique fracture. And if we look at sequential images, I'm pointing out for you here the fractures of the skull and the extension. I'm going from posterior to anterior. And on the right, you see there is an extension to the TMJ, to the articulation here, to the joint. We see some air in both sides here at the joint, temporomandibular joint. And you see on the right that there is also a fracture of the wall, of the lateral wall of the carotid canal. And we see there is hemosinus everywhere, so there's no doubt we have a skull base fracture here. We see the fracture of the carotid canal on the right, and we see as well a lot of fractures involving the paranasal sinus cavities, okay? So what are the possible complications of skull base fractures? So vascular and cranial nerve injuries, migration of a digestive catheter to the intracranial compartment. That's why we should always avoid a nasal insertion of a catheter, okay? We should always insert the catheter through the mouth and not through the nose, okay? This is very important. There's always a risk of fistula, of CSF fistula. Most of them, traumatic CSF fistulas will resolve spontaneously, but a little fraction will require surgical intervention. And we should not forget about the possibility of infection, okay? That would be a little bit delayed, but it can absolutely happen, so we should keep it in mind. So still about case number 3, some more images. So we see bilateral subgaleal hematomas and subdural hematomas as well. We have subarachnoid hemorrhage along the falx, also. And we have bilateral subarachnoid hemorrhage as well. We see along the tentorium of the cerebellum bilaterally, and we confirm here as well the hemosinus that we had already seen in the bone images. And here we have a very interesting signal that would be the presence of blood in the chamber, the vitreous chamber here on both sides, and along the CSF that is involving here the right optic nerve. So this is a very important signal. It's called Terson syndrome, and it's a sign of bad prognosis, okay, that we had found in this patient. So case number 4 is about a 40-year-old kart racer that was involved in a rollover accident. This is a case that I have lived, as all of the others that I'm showing you. So I remember very well when he came. So he had a good general state. He was okay, but he had this little subarachnoid hemorrhage in the middle line, as well as a fracture, not very displaced, of the orbita. And also he had a frontal contusion, okay, with a very small hemorrhagic foci. And he had some cervical fractures. So we see here on the right, on many levels, fractures of the vertebral foramen. Okay, so when we see this kind of things, we should absolutely inject and search for dissection. Okay, search for obstruction and arterial lesions. So in this case, we found it. There was a traumatic dissection of the right vertebral artery. And not only, he had also a dissection, he had a flap of the internal carotid artery on the left. And when we did the reconstruction of the CTA, we saw that he had already a pseudoaneurysm in the acute phase, okay? So this patient was followed. He repeated the CTA 3 days later, and we saw that the pseudoaneurysm has really grown, has doubled in size in 2 days. So this case was extensively discussed, and he finally, the medical team has decided to treat this pseudoaneurysm in the acute phase. So this patient was submitted to an endovascular repair of this pseudoaneurysm, and it was very successful. The patient was discharged very well. So case number 5 is about a 79-year-old male that had a cardiorespiratory arrest immediately after a ski accident with head trauma. So here we see that this patient had an important subarachnoid hemorrhage. We see also a little bit of hemosinus here. And then when we injected the contrast, there was an active extravasation of the contrast, which is really, really bad in this context here. And we saw that he had a fracture that was called a keyhole fracture of the sphenoid bone, and the basilar artery was entrapped. Okay, so we see here the basilar artery inside the left sphenoid sinus. And this patient still did an MRI that confirmed that he had a ischemic stroke in the pons. So unfortunately, he died after the MRI. So some cases that are not very typical, but should be properly interpreted. So think about vascular injury. This is the message. I have shown you some different cases, and all of them had vascular injuries. So when to do a CTA? CTA is required if you have a high kinetic energy or you have an acceleration deceleration trauma mechanism, when we have any kind of penetrating injury, or we have a skull-base fracture involving a vascular or a cranial nerve canal. Okay, these are situations when we should absolutely do a vascular study. Here's another case, case number 6, a 20-year-old woman that was slapped in the face during an argument. So this patient came with a paralysis and paresthesis on the left side, and then she did an MRI. Here are the diffusion weighted images. We see that she had a lot of areas of restricted diffusion here on the superficial territory of the middle cerebral artery, but as well as in the deep territory. And when this patient had 3D TOF, an MRA, we saw there was a very important change of the caliber of the right middle cerebral artery here, associated to a prolongation of the mean transit time and augmentation of the time to peak. So everything was consisted with a dissection, with an intracranial dissection. So remember that intracranial dissections can be spontaneous, but can also be caused by trauma, in this case, a slap in the face. So about traumatic dissections, the degree of clinical suspicion is usually low, okay? So if you don't think about it, you're probably going to miss it. Arterial dissections are usually not easy to recognize on CTA, so we should absolutely search in all planes, axial, coronal, sagittals, with and without MIP reconstructions. Because if we only look at MIP reconstructions, we might miss subtle findings. So we should look twice, okay, with and without MIP in each plane. And traumas with high kinetic energy can trigger intra or extracranial dissections, and other factors that also may be implicated are uncontrollable cough, okay, neck hyperextension in lavatories, chiropractic manipulation, and long phone call conversations, especially if the patient has an ego syndrome, if the patient has a prolonged styloid process, okay? So pseudoaneurysm may be an early or a late complication. We should not forget about it, and we should search actively for that. In cervical trauma, CT, look for fractures of the transverse foramina before you leave the patient the CT room, okay? Actively seek for signs of vertebral artery injury, and if you are in doubt, inject, okay? And look for vascular injury if you have a very important mechanism of trauma. These are important lessons. So here is case number 7. This was a 30-year-old man that was a construction worker and had a scaffolding fall. So here we see a steel bar that is transversing the head of this patient. Here we have an example of a penetrating wound. Here we see the CT. He has a lot of metal artifacts that obscure the analysis of the parenchyma. Here is very difficult in some images to identify what's going on, but we see a little bit of probable subarachnoid hemorrhage. We see intraventricular hemorrhage as well. And this bar was removed by neurosurgery. And then afterwards, the patient was able to undergo an MRI. And we see the extreme damage that happened to this patient. We see the hemorrhagic residues here, subgalleo hematoma, extra axial, subdural collections. So a very dramatic kind of penetrating wound. Here is another example. A patient, a 38-year-old woman attacked during a robbery. So this patient was lucky enough to have the impact of the projectile in a B frontal path. So here she stayed alive after the assault, but we see that unfortunately both frontal lobes were here blessed. Injured. So this is an example of a gunshot wound. Here is an example of Osborne's book that I find very illustrative. So here we see the hole that the projectile did when he entered. So we see a rectilineous path here and a lot of secondary fragments from the original bullet, okay? So remember that when this bullet enters, it's not only the mechanical damage that it does, but as well a thermic damage because it comes in very hot. And afterwards, the the bullet has hit the bone here, has entrained a secondary lesion here, and sometimes you can have bone fragments that are going to act as second bullets, let's say. And in this case, the direction of the bullet has changed after touching the bone, and the bullet stayed there. It didn't come out, okay? So you won't always have an exit hole. Sometimes you only have an entry hole, as we see in this case. So about gunshot wounds and forensic implications, important factors to consider for the parenchymal damage is the energy of the impact on the bone, the area of contact, the bone thickness at the point of impact. The projectile entry wound is, as a rule, smaller than the exit wound. Sometimes this is important for legal questions, legal issues. So we should try to state in our report what probably is the entry wound and what probably is the exit wound if present, okay? So we should remember that bullets with high kinetic energy can transfer its energy to transform bone fragments of the entry wound into secondary projectiles. And the report should describe, as I said, the location, characteristics of the entry wound, the wound tracts, including bone fragments, ricochet, vascular lesions, signs of ischemia or herniations, and if present, the exit wound as well. So case number 9, we have 12. I'm almost ending. So case number 9 is about a 25-year-old bike accident, it was a female, 25-year-old female patient that had a bike accident with retrograde amnesia. So here on the CT, we see a subgalleo hematoma here in the left parietal convexity. And if you look very careful, there are some hyperdensities here on the left superior frontal gyrus, and the same thing here in the cortico-subcortical transition here. So you can see better with the arrows. So this should make us think about one specific lesion that would be diffuse axonal lesion, okay? So this would be the tip of the iceberg. If we see this on CT, we should absolutely do an MRI because we're going to find more, okay? So here, as I said, this patient went for the MRI. So on the left, we see diffusion weighted image. We see some hyperintense foci. That also is hyperintense on flare. And we see the susceptibility artifacts on susceptibility weighted image. So as I said, we see much more on MRI than we saw on CT, okay? And here, remember, the patient had this symptom of retrograde amnesia. So it was interesting that she had a lesion on the fornix that would explain that. And we also see some other peripheral foci of diffuse axonal image, diffuse axonal lesion. Another one in the right posterior branch of the internal capsule, and a deeper one in the transition of the thalamus to the left peduncle, cerebral peduncle here. So about diffusion axonal injuries as well, sometimes we can see much more on CT, but if we can see as much as that, probably the patient is really, really bad, because we're going to see much more in the MRI, okay? So this is an example of dissociation from what we see on CT to what we see on MRI. So here we should remember that we have this grading of diffuse axonal lesions in 3 grades. So the most superficial lesions are the less severe, okay? So it would be type 1. And then when we have lesions that touch the corpus callosum, it would be grade 2. And then we have deeper lesions that touch the brainstem, that would be grade 3, okay? So here's another graphic example just to let you know. So this would be caused mainly by shearing, okay, of axons, and it's not mandatory that we have hemorrhagic lesions. Sometimes we don't have hemorrhagic lesions. We only see lesions on diffusion, weighted image, and flare, but most of them would have an hemorrhagic component together. So remember about that. So what about diffuse axonal injury? Is the second most common type of parenchymal lesion in cranioencephalic trauma, only after cortical contusions. Patients with diffuse axonal injury usually present clinical radiologic dissociation. What does it mean? It means that sometimes the CT is okay and the patient is not okay. So we should think about it and we should do an MRI to try to understand what's going on. Okay, so remember, direct impact is not a condition for diffuse axonal injury, and most patients with this do not have fractures. So we come back to the story of the X-ray. Okay, so initial CT scans usually show no changes, and 10 to 20% of follow-up exams will show edema and or bleeding, only bit lately. Okay. So case number 10, a 26-year-old woman with diplopia after a motorbike accident. So it was on the left, and she did a little bit of diffuse axonal injury, grade 1 here, and the superior frontal gyrus on the left. When we did a 3D T2 CIS imaging, volumetric image, there was no there was no thickening, there was no discontinuity of the third nerve on each side. But when we injected, we saw that on the left oculomotor nerve, we had a little bit of enhancement. Okay, so we can see in the axial image and we can see it in the coronal imaging as well. So she had a little bit of enhancement, and we know that an isolated oculomotor nerve palsy following minor head trauma, it exists. It's something that we should actively search and remember. Okay, so this is not a very usual case, but it's to stress the importance of knowing what is the reason that made the patient come. Okay, so we should absolutely know what is going on with the patients in order to read the study properly. Okay, we should not neglect anamnesis. This is very, very important, especially in neuroradiology. So talking a little bit about herniation syndromes, just to remember, we have type 1 that would be subfalcine, we have type 2 that would be uncal, we have type 3 that would be tonsillar, we have type 4 that would be diencephalic or central herniation. And this can happen because of a tumor or because of a hematoma or anything that occupies space. But we can also have this kind of lesion in the infratentorial compartment, and we may have compression of the brainstem and upward cerebellar herniation. We should remember about it. Bon, 11th case, we have a 52-year-old man that's cirrhotic. He had already been operated for a subdural hematoma on the right. So here we see the pneumocran on both sides. So this patient had a rebleeding after the first surgery. We see a very important deviation of the midline structures. We see a midline shift. We see as well that there's huncal herniation here because of this rebleeding. We don't see very well at all, I would say, interpeduncular cistern. We don't see perimesencephalic cistern. We have a complete effacement of the basal cisterns, and in the lower parts of the brainstem, on the upper parts of the brainstem, in the lower images here, we start to see some brainstem hemorrhage in the mesencephalic and pontine compartment that is consistent with a Durée hemorrhagie. Okay, so this is a very, very bad prognosis for the patient because of compression of circumferential arteries coming from the basilar artery, and as well branches of the posterior cerebral artery. So this is a very, very bad prognosis finding. So the last case that I want to show you is about a 40-year-old man that had a motor vehicle collision 2 months before. So this patient came with a non-displaced fracture on the left, on the parietal bone, that also extended to the temporal bone. So we see the mastoid here that has a little fracture. And we see here in this image that is a discontinuity of the posterior wall of the left sphenoid sinus. That's something a little bit weird, but let's go on. Well, in the soft imaging, in the soft tissue imaging, we see a very important asymmetry of the cavernous sinus. We see on the left that it's very enlarged. And as well, there is an important enlargement of the left ophthalmic vein and apoptosis, okay, on the left. So all of that, even if we don't have contrast enhanced images at this moment, this should make us think about a carotid cavernous fistula, okay, a post-traumatic fistula. So this would be a schematic drawing just to show you that because of the trauma, there is the mixing of the arterial blood coming from the internal carotid artery, mixing with the venous blood of the cavernous sinus, and of course is going to cause some neuropathy, some complex neuropathy of the cranial nerves that pass just along or inside the sinus, the cavernous sinus. So here an example of the literature, a patient with chemosis, proptosis, that underwent an angiography that confirmed the fistula, and after the endovascular treatment, the patient was properly treated and the ophthalmic complications regressed completely. So I hope these informations can help you in the future, and I'm available to your questions. And thank you very much for having me today. And I'm available to answer anything that I hope I will be able to. Okay, thank you.
Thank you very much, Dr. Dalaqua. It was a wonderful presentation and I thoroughly enjoyed it. So we have a few questions from our audiences. So the first question is, should we always report the 23% of missed intracranial findings on X-rays and suggest CT scan?
In fact, my message here is that we shouldn't do at all X-rays in the context of head trauma, but if you absolutely have to report it, then yes, you should absolutely write and protect yourself and the patient, saying that this kind of imaging is not enough to completely exclude an important lesion, and absolutely suggest a CT, yes.
Thank you. So when you see epidural and subdural hematoma, do you report the volume?
I usually don't report the volume, but I think it's very important to report the thickness. So usually I try to measure on the coronal plane. Of course, you're going to measure in the plane that would minimize the hyperestimation bias, okay? So if you have a convexity hematoma, the coronal plane, you would look at it from anterior to posterior. So I think you're going to minimize the overestimation. And what I like it very much is to do some key images. So the next one that is going to report the follow-up exam, he or she can know exactly where you have measured and can try to reproduce it in a most reliable way.
Okay. Okay. So when should we report the extradural collection volume?
I guess volume is not obligatory, it's not mandatory to report the volume, but as I said, I would report the thickness. I guess this is the most important. And of course, not only the thickness, but what is it causing? Is it causing a midline shift? Is it causing a herniation? So is it causing sulci effacement and all of that?
Okay. So do you think like your institution uses any specific guidelines for head injury?
There are many guidelines. In fact, I don't know exactly what my urgentists in this institution use, but there are many. There are the Ottawa, there are the NICE, there are many guidelines. So I wouldn't say specifically that my institution uses the NICE guidelines, but I can say that usually there are some regional consensus for each institution.
Okay. So what's the role of DTI on head trauma?
Well, DTI absolutely has a research role that we see a lot of publications about it. But in all the institutions that I have already worked, we don't do it routinely for head trauma because there is no data that would support the clinical utilization of FA, of fractional anisotropy for clinical practice. So as long as there's no database for that, I don't feel comfortable to utilize that in the clinical practice yet.
So what are the main indications of MRI in acute trauma?
So there are very few indications in acute trauma. As I said, CT is much more faster, available, and reliable because sometimes you don't know if the patient has a contraindication to MRI. So I would say that 99% of cases, we should do CT and CTA. And for the patients that would have a persistent clinical radiologic dissociation that probably have diffuse axonal injury, then I would go for MRI earlier.
Okay.
Okay.
So if you see hyperdensity in the cerebral sulci, is it ever a question of subarachnoid hemorrhage versus a traumatic parenchymal hemorrhage?
Sometimes it's very difficult to say. In most cases, it's a subarachnoid hemorrhage if it has the same morphology of the sulci, but sometimes you may have very superficial cortical injuries that could simulate a subarachnoid hemorrhage. But if I'm not sure, what I do is to say we have just a cortical hemorrhage. And afterwards, in a follow-up exam or in an MRI, you're going to be sure what is it about.
Sure. Thank you very much.
Okay. So thank you very much as well.
Dr. Dalaqua, I also want to let you know that you're receiving greetings from all across the world. Excellent lecture from Enrique, excellent review from Margarita, Dr. Jacqueline. Thank you very much for this wonderful presentation. Readings from Mexico, you're receiving from Patricia, Doctor. We have so many people. I can't see all of them.
Thank you. I'm happy to contribute in this moment that we're living with something that I can share.
Thank you very much for doing this for us, and we are very grateful to you for this. And thank you very much to all of our audiences for joining us today. And we look forward to you all in our next Health for the World International Grand Rounds. Thank you very much. Have a good one.